Good morning, everybody. Welcome at the session on central serous chorioretinopathy. Thank you for coming here. Central serous chorioretinopathy is a mysterious disease, but fortunately, in the recent years, quite a lot of new insights have appeared on the pathogenesis, the differential diagnosis, and also the treatment. So in this course, we want to give you an overview on these three main topics. And in that regard, it's a pleasure to introduce my colleague, Dr. Elon van Dijk, who's going to first talk about the pathogenesis of central serous chorioretinopathy.
Could we maybe close the doors? Thank you. Because my timer of my 11 minutes is already starting, so we have to, let's say, start about talking about the pathogenesis and diagnosis of central serous chorioretinopathy, our personal hobby. So it's a pleasure to have so many of you here so that we can really try to, let's say, discuss a lot. Central serous chorioretinopathy after age-related macular degeneration, diabetic macular edema, and retinal venous occlusion. It's the fourth most common wet maculopathy. On this fundus photo, you can clearly see the serous subretinal fluid here exactly in the fovea. On OCT, this fluid can be better appreciated. Usually it's present in the fovea, and sometimes it's also present extrafoveally. And also several choroidal characteristics can be appreciated good on the OCTA, for example, a thickened choroid or the pachyvessels. I will come back on that later. In order to diagnose a central serous chorioretinopathy, it's of the utmost importance also to make an FA and an ICGA. Usually on that FA you can see the leakage through the retinal pigment epithelium, for example here, but even more clearly here. And on the ICGA, usually on the mid-phase ICGA, you can see the hyperfluorescent areas with an indistinct border, and these areas are really typical of the CSC and make your diagnosis and are important for choosing your treatment spot during the photodynamic therapy. CSC is part of a disease spectrum. So you got acute CSC, chronic CSC, severe chronic CSC, and also CSC can be complicated by either a macular neovascularization or polypoidal choroidal vasculopathy. So an acute CSC typically has a smokestack of leakage on the FA, like here. So this is the early phase FA and this is the later phase. And usually the subretinal fluid in these type of patients resolves spontaneously within 3 to 6 months. So in these patients in general, you can just wait and see, no treatment needed in the first instance. A chronic CSC, multiple ways are available that the disease can present, but also, for example, with the terrible atrophy, like in this case, and lots of intraretinal fluid. So the presentation of the chronic CSC is way broader compared to acute CSC. But even in chronic CSC, spontaneous resolution can occur. In the large Fiji trial from the UK, up to 30% of the placebo-treated chronic CSC patients, they had spontaneous subretinal fluid resolution at 1 year interval. So also when you don't treat your chronic CSC patients, sometimes the fluid goes away. There are several parameters that can be predictive of that spontaneous resolution, both in acute CSC and in the chronic CSC. You can easily understand that when there's a lower number of leakage points on the fluorescein angiography, there's a bigger chance that the fluid will go away. But also when the subretinal fluid has an orientation like the Mount Fuji, so a bit more flat, as you can see on the OCT image, we found out that the chance of spontaneous resolution is 3 times bigger compared to, let's say, a more dome-shaped subretinal fluid accumulation. In this patient, you really see that the abnormalities on the ICGA are far more widespread compared to FA. So CSC really is a disease of the choroid. It's part of the pachychoroid disease, and also that pachychoroid disease spectrum is a spectrum. So you have uncomplicated pachychoroid pigment epitheliopathy, CSC, and PNV or PCV. I'll come back to a few of these diseases later on. In pachychoroid pigment epitheliopathy, there is no subretinal fluid. And usually there is also no area of leakage on FA, or maybe that area of leakage on FA has already disappeared. But on the ICGA, you can see those widespread abnormalities that are really characteristic of the diseases that are part of the pachychoroid spectrum. So even when there's no fluid, the choroid in this patient is sick, so you need to keep an eye on him or her. Then there's polypoidal choroidal vasculopathy. And I mainly want to address a few, let's say, characteristics on OCT that could direct you towards the presence of a polyp. Sometimes it's the case that the polyp, like here, occurs at the edge of a relatively flat pigment epithelial detachment with hyperreflective content. So there's a macular neovascularization, not always within the context of CSC. And at the edge of that macular neovascularization, there's a relatively steep pigment epithelial detachment which could be characteristic of a polypoidal choroidal vasculopathy. Usually you would also do FA and ICGA in order to confirm your diagnosis, but even on your OCT you can have quite a good clue in order to find out if it's maybe a PCV. And then when you have a look in the literature, you can find all kinds of very, let's say, fancy terms that people find out and they immediately want to provide their name to let's say, a sign on the OCT. But I think it's relevant that when it's a bilobular RPE detachment, like here, so when there are two lobules, or when it's the very steep RPE detachment, can you close the door, please? Thank you. Then it's really a sign of a polypoidal choroidal vasculopathy. It occurs quite often, CSC, but its exact pathogenesis is unknown. So there are several factors that have been found to be of importance. So sex, it occurs more often in male patients, so 6 times more often compared to female patients. And also age. So usually it occurs below the age of 55. When it occurs at an older age, then the chance of the presence of a macular neovascularization is a bit bigger. And then we talk about genetic factors. So are genetic factors of importance in CSC? At least we know that it's often a bilateral disease that occurs quite symmetrically, and that there's something like a racial predisposition. So it does not often occur in African Americans, for example. And there are also like familial cases, like there are familial cases of the pachychoroid disease. So I think there is at least something genetic playing a role, but there are other factors that are important too, to which I will come back soon. Several genes have been identified that have been linked to CSC. The most important genes that have been linked to the disease are in the complement system, so that's part of the innate immune system. But also stress and steroids have been found to be of importance. So let's say exogenous steroid use has been found to increase the risk to develop CSC with 37 times, or up to 37 times. And exogenous steroid use has been mentioned in up to 52% of all patients. Okay, quite a lot of patients use steroids anyway, but this is the most important risk factor for the disease. And also the Cushing syndrome, so endogenous hypercortisolism, has been linked to CSC. A typical textbook Cushing syndrome is quite easy to diagnose, so a moon phase, fat spats, hypertension, diabetes mellitus. But sometimes it can be a bit more challenging, and then even CSC can be one of the presenting features of that endogenous hypercortisolism. So when you find out that a patient, for example, has a moon phase or hypertension or diabetes mellitus at a relatively young age, always think about Cushing syndrome, and you could consider to refer the patient to the Department of Endocrinology. Then there has always been a debate regarding stress and CSC. So already in 1987, the legend Lawrence Januzzi published about stress and ambitious people, outgoing people developing CSC. And we tried to systematically review patients with CSC in order to find out if there were any characteristics that could direct us towards Cushing syndrome, or let's say a strange way of coping stress. We did a clinical examination, we took blood samples, saliva samples, and we did a validated questionnaire. And we didn't find any, let's say, clear signs of Cushing syndrome in any of the patients. So we then think that there's no need to do systematic screening for all Cushing syndrome patients, but sometimes you would have an indication to do so. We found some hyperactivity of the HPA axis because the patients had a relatively high 24-hour urine cortisol, but there was preserved rhythmicity. So all by all, there were not that many marked differences when we were screening all the CSC patients. And we also did not observe the type A personality too frequently, and there was also no abnormal stress coping in this prospective study. So that was the first prospective study that studied quite a lot of CSC patients. There are several other factors that are often mentioned and that need to be, let's say, addressed in the pathogenesis or the risk factors of CSC. Shift work, OSAS, hypertension, sleep disturbances, and allergic diseases. But you would immediately find out that quite a lot of people will have these risk factors. So it's always challenging to link specific risk factors to a disease that occurs quite frequently. So I don't know what we need to do with this information, but at least you can, let's say, use it. Then there were several recent findings, mainly based on ICGA, in which they find out there were, let's say, abnormal venous patterns, so abnormal linkage to several quadrants that could, let's say, lead to abnormal venous outflow in your CSC patient. And the term venous overload chorioretinopathy was coined by Professor Spade. You then see something like venous congestion, abnormal venous drainage. You don't see any clear watershed zones between the several regions in the eye. And there's also like delayed filling and ischemia of the choriocapillaris. But yeah, what's, let's say, key in all these factors is quite challenging to find out. But at least there's something happening in the choroid that leads to the subretinal fluid. Importantly, you also find these abnormalities in the fellow eye of patients with CSC. So not only the affected eye, but also in the other eye, you will find similar abnormalities on ICGA. And there is something wrong with the sclera, whatever it is. There is something like choroidal vascular congestion and leakage. These features are pivotal in the CSC pathogenesis. This is an important target for the treatment. Later on in the treatment talk, we will further discuss that. So my conclusions, genetic factors are of importance, hypercortisolism is of importance, but the exact translation to real life is a bit challenging. There is no subclinical Cushing syndrome in general in CSC patients. Still, you could consider to refer a few of your patients when you don't understand other systematic complaints. There is some hyperactivity of the HPA axis, but preserved rhythmicity. So the translation to what it means for your patients is a bit challenging. They don't have any differences in perceived stress, even when you compare active and inactive CSC, and there's no specific personality type that has an increased risk to develop CSC, and no abnormal stress coping. Some novelties, scleral factors and venous overload are of importance, and the differential diagnosis of CSC gets broader every year. We will come back to that later. Thanks a lot. And now I'll hand over the floor to Dr. Susanne IJzer from Radboud UMC, Nijmegen, the Netherlands. She will talk about the differential diagnosis of CSC.
And the questions will be, the discussion will be at the end of the talks.
There you go. Ja, en als je deze indrukt, dan kan je dus op het scherm wijzen. Dan zie je.
Dankjewel. So, good morning, everyone. So, yes, I'll be talking about the differential diagnosis of central serous chorioretinopathy. If you want to read more about it, you can find it in this beautiful paper written by Camille and Elon. So, like Elon just discussed, when we look at central serous chorioretinopathy, we look at the presence for subretinal fluid and abnormal choroidal vasculature. Certain FA and ICGA characteristics, but we also look for other signs or retinal changes that may guide us to the differential diagnosis. The differential diagnosis of CSC is very broad, but it's very important that you actually know it or are aware of it, because it may prevent unnecessary treatments and it may actually save a life. So this is the differential that I will be discussing. The first example is of a 23-year-old healthy male who was actually seen by us because of glaucoma in his family. So he was just there for glaucoma screening. And the subretinal fluid was seen. Multimodal imaging was performed because of the presence of subretinal fluid and these changes in the choroid seen on the OCT. But actually, if you look at the fundus photo, so just by fundoscopy, the diagnosis is already clear. This is torpedomaculopathy. This is congenital, and the patient is not experiencing any problems. And this is something that's stable and will be like this for the rest of his life. The next case is a 9-year-old girl who was actually treated for occlusion therapy because of her, her visual acuity was stayed behind, and first she was alternating treatment, the occlusion treatment with occlusion in her right eye, then her left eye, so that's kind of strange already. Here are the fundi, and at one point an OCT was made and subretinal fluid in the right eye was seen. The choroid is not very thick, but for a patient with a refraction of -13, you may actually consider this a thick choroid. Since she was only 9, we only made an FA, like oral FA, but there's no leakage here. So is this central serous chorioretinopathy? I don't think so. We made some extra OCT, so if you compare here the vertical and the horizontal scan, this is a dome-shaped macula. The next patient is a 25-year-old healthy male who was seen at the emergency room because of loss of vision in the left eye. OCT was made, subretinal fluid was seen, so he was referred to me. And indeed, there are some changes in the choroid as well. Here's actually the OCT of the fellow eye, and he had never complained of this eye, but look at this area here. You see how it changed over time? So by the time the patient saw me for a consultation, this was actually the OCT in his left eye, so I was lucky, like I didn't have to do anything. But I asked him a specific question, and I was like, did you experience any pain when you had this loss of vision? And he said, yes, yes, yes. And I had to take a lot of ibuprofen to get through the day. And this is posterior scleritis. A 51-year-old male who was seen because of central serous chorioretinopathy in the left eye. He returned in 2011, and this is something that Elon just discussed. Indeed, subretinal fluid and a thickened or abnormal choroid, which is to be expected because he already had the diagnosis of central serous chorioretinopathy. But here are the peaked, confluent PEDs, and this is type 1 macular neovascularization secondary to central serous chorioretinopathy. So this is a very important diagnosis because, of course, this warrants a different treatment. And we see it usually in absence of drusen, maybe a few pachydrusen at younger age. And this double layer sign with these small peaked PEDs is very typical for this image. The next case, a 29-year-old healthy male. He was also referred because of central serous chorioretinopathy, and indeed there is subretinal fluid and an abnormal thick choroid. Here's the FA, and I think the FA may actually be compatible with central serous chorioretinopathy, but if you look at the ICGA, you see the washout in the late phase. And this is circumscribed choroidal hemangioma. This case is a 77-year-old male who was referred also because of central serous chorioretinopathy, and this was the first OCT that we made, and we were so happy with that. Cannot believe it right now, but we were really impressed with this image. So we found subretinal fluid in this case. He was, of course, we couldn't say anything about the choroid here. He was treated with PDT, he had anti-VEGF injections, and you see the change in the presence of subretinal fluid, but this is actually because the OCTs were made at a different location. We didn't have the eye tracking at the time. And when I saw him, he also had the subretinal fluid in the fellow eye, and look at the FAF. So I just looked at the patient and I said, you know, this is such a symmetrical maculopathy. I think this may be something that you inherited. And the patient looked at me and said, doctor, could this be Best disease? And I was like, oh my God, that's like a brilliant idea. How do you come up with that? And then he said, well, my mom has Best disease and so does my son. But that was never something that was discussed earlier. So make an FAF and look at the symmetry. This case is a 43-year-old female. She was also referred because of her loss of vision in her right eye. There was subretinal fluid there, choroid not very thick. There were changes in the left eye as well, although she was not complaining of that eye. And here are the fundus images and the FAFs. Angioid streaks, spot orange. So this is pseudoxanthoma elasticum. these patients need to be referred to internal medicine or specialized hospitals. They can have aneurysms and from the aorta, so it's very important that they get a workup. This is a 64-year-old male. It's actually a patient from a study published by Elon. He was treated because of metastatic cutaneous melanoma, and he was treated with MEK inhibitors. This is something that may resolve even upon continuation with the treatment. So this is my final case of today. It's a 27-year-old female. She was hospitalized at the neurology department because of sudden onset of nausea and vomiting. She had paresthesia in her hand and in her face, and she had pain in her belly. She had an acute drop of visual acuity in the left eye, and that's why she was referred to us. We made the OCT, but she was actually too sick for like fundus photos and everything else. So she was returned to the neurology department. And so we sat down and we looked at it. It was like, this looks like acute central serous chorioretinopathy, even with these changes here. Like, what is this? Subretinal fluid, abnormal, changes in the choroid. So we thought this is acute central serous in a very sick patient. She has hypertension, elevated liver enzymes, thrombocytopenia, pain in epigastrium, and she has nausea and vomiting. Any suggestions? So we thought, could this be HELP syndrome? So this is what we told our colleagues from neurology. They did additional imaging. I think there were easier ways to find out if someone was pregnant, but indeed she was pregnant, and labor was induced. She gave birth to a healthy son. We saw her back a couple of weeks later, and this is what her OCTs looked like at the time. So here's a quick overview of the differential diagnosis of central serous chorioretinopathy. Again, it's very important to be aware of the differential diagnosis and be aware of the fact that a correct diagnosis may actually save a life, or like we saw in the last case, save 2 lives. Thank you for your attention. Our next speaker is the chair, Camille Boon.
And when there are questions from the people who are listening to us from home, please post them in the Q&A so that we can easily go through them at the end of the talk. Thank you.
Thank you. Yes, so now we continue to the treatment part, which is also a challenging aspect, I think, of CSC. My image, oh no, my image is back, okay. Because central serous chorioretinopathy, should we treat, is the first question. And the answer is yes, especially in cases with chronicity, because it can lead to irreversible vision loss and a decreased quality of life. It's not a super severe disease that you have to treat very fast. You can wait and see if there is spontaneous resolution, especially in acute cases. But I would have a low threshold to treat in chronic cases. And interestingly, there is a very variable treatment pattern in different countries, even within Europe. And I'm going to address that controversy and try to give some kind of direction in terms of what the best treatment should be nowadays. And this is very much connected to the insights in the pathogenesis that Elon already showed you. So there is an interaction between pathogenesis and the treatment of choice and the efficacy of the different treatments that have been discussed and published. And a key message here, as Elon also extensively showed, is that the choroidal vascular changes, the congestion, the leakage are pivotal when it comes to the pathogenesis of CSC. And this means that we have to treat this to try to get rid of the fluid. And also, as Suzanne already showed you, it's very important before you dive into the treatment of so-called serous maculopathy that you think about this very broad differential diagnosis. She also highlighted the paper that we previously published. You can download it for free. You can also scan the QR code, and it's good luck because it's quite extensive. Now we go to the treatment, and over here, I think this is disease par excellence that is very important to take into account whether or not the evidence is strong or not. Because if there's one slide that I would recommend you to remember, it's this one, and Elon already shortly alluded to this. This is a supplementary table, which is actually buried somewhere in the online-only supplements of the Vici trial. And the Vici trial was a trial, the first prospective randomized controlled trial from the UK, investigator-initiated that, compared oral eplerenone treatment to oral placebo treatment. Now have a look at this. So on the left is placebo, right is eplerenone, and at 12 months, 30% of the placebo-treated patients had a complete resolution of supraretinal fluid on OCT. And by the way, an additional 24% had a partial resolution. So more than half of them had an improvement or a complete resolution, compared to, by the way, only 16% of the eplerenone-treated patients. And the authors rightfully concluded that there is no place for eplerenone as a primary treatment of central serous chorioretinopathy, because it simply doesn't seem to work. But it also shows you that even in chronic cases, whatever they may be, because it's a difficult definition, there may be spontaneous resolution, which complicates the interpretation of retrospective studies. You could give them a bag of M&Ms every day and then show that 30% have a spontaneous resolution after 12 months. But this is simply probably a placebo effect and bad for your teeth. Now, that's why we need prospective randomized controlled trials. And personally, I think that the aim of treatment should be quite radical in the way that we want to get this neuroretina back on their natural housekeeper, the retinal pigment epithelium. And with time, if treatment works, you can see that the ellipsoid zone can reconstitute if you don't wait too long, if there's not atrophy already. You want to get those photoreceptors back on top of the RPE. And there's a miraculous capacity of regeneration if you're not too late with treatment. So get those photoreceptors back where they belong. But of course, you would also like to reduce or prevent recurrences by addressing this primary problem, which is the choroid. This is an interesting illustration, this case of a man who had relatively subtle, although multifocal changes on FA with chronic CSC. But here you see the ICGA. You see that the abnormalities in ICGA are much more extensive and probably lie at the basis of the disease. What you see on FA and OCT is just the tip of the iceberg. Now, when looking at the treatment options, several of them have been described, and the most important ones are listed here. And, well, we already discussed the fact that eplerenone or mineralocorticoid receptor antagonists, although spironolactone has not been studied that extensively, do not work. There is also not a place for anti-VEGF treatment when there is no neovascularization. Conventional laser treatment of an eccentric leak, especially when PDT or micropulse laser is not available, you could consider that, but be careful because you could induce neovascularization or scotoma. But the most important ones I'm going to discuss are PDT and micropulse laser treatment. And the rationale of PDT is that you cause, in this thickened, leaky choroid, which is very different from what you see in AMD, you cause a remodeling of the choroid so that the choroid quiets down a bit. The thickness becomes less pronounced. You see less leakage in ICGA after PDT. And it has also been shown if you reduce the dose to half the dose or half the energy or half the time, although most data are on half the dose, and you can split the vial, so you can treat 2 patients with 1 bottle, that it is equally effective and even safer. I'm quickly going to address acute CSC, but mainly going to focus on chronic CSC because they're quite different. As you know, acute CSC patients tend to resolve spontaneously, at least in 90% or more of them, and they have a much more favorable prognosis. Here will be a typical case with a focal leak, but there are some studies also showing that if you perform early PDT, one of the studies is from our group in a group of almost 300 patients, but it was retrospective, by the way, that there was a less likelihood of recurrence with early treatment. So especially in patients who rely on their vision for their profession, let's say a surgeon or a bus driver or a pilot, you could consider early PDT treatment also to reduce the risk of recurrence. And there was one relatively small but good prospective trial from Asia already quite some years ago that showed that there was also potentially a best-corrected visual acuity benefit, and also in terms of persistent fluid, as you can see below. Now let's switch to the main problem, which is chronic CSC. And we performed in a European multi-center investigator-initiated setting the first prospective trial comparing half-dose PDT to micropulse laser treatment. This was the PLACE trial, where we performed ICGA-guided treatment because we wanted to treat as much as possible also the choroid. So we used a relatively large spot of PDT, and with micropulse laser we used a kind of painting of the area that was abnormal. So we want to have an extensive treatment, also not to undertreat. by also including the FFA hotspots and also the subretinal fluid areas on OCT. And we use standard half-dose PDT settings listed here. And back then, 810 nanometer micropulse laser was the gold standard, if you can speak of a gold standard back then. And we used that. It was an infrared micropulse laser with 1800 milliwatt, so relatively high power, because we did not want to undertreat. And it was a sub-threshold treatment, so no visible burn, of course, because otherwise you're in big trouble. Here are the settings. So the primary outcome parameter was anatomical success, so a complete resolution of fluid on OCT, and the secondary outcome parameters were functional parameters, so BCVA, microperimetry sensitivity, and a vision questionnaire, quality of life questionnaire. And we found a markedly higher percentage of complete resolution in the PDT-treated group compared to the micropulse laser group. And also the PDT was more favorable in terms of an increase of retinal sensitivity on microperimetry. So we concluded in the study that was published in Ophthalmology already quite some years ago that photodynamic therapy is more effective than micropulse laser for treating chronic CSC. And then people started to say, okay, but maybe with focal leakage, micropulse laser might be equally effective. So we were able, although the study was not powered for that, we were able to look into those subgroups, and actually we found that it didn't matter. PDT was also superior with focal leakage, and of course also in diffuse leakage. And what we also found was that so we found that micropulse laser was unfortunately not that successful, at least not with this wavelength. But we also found that when patients did not respond to micropulse and then were treated with PDT, in the replace trial, we found that PDT was still very effective, but not the other way around, unfortunately. Now, in recent years, 577 nanometer micropulse laser has emerged as a potentially more effective alternative. But there are no good prospective studies until recently, when last year in Ophthalmology Retina, there was this study published by an Asian group comparing half-dose PDT to 577 nanometer subthreshold micropulse laser. And what they found was, despite the fact that PDT had showed a faster resolution, a higher percentage on all time points in subretinal fluid resolution, and a better BCVA at 3 months, that at 12 months there was not a statistically significant difference in these parameters. But there are some potential problems with this study, I must say, because they had relatively low patient numbers, and they defined chronicity in contrast to, for instance, our studies, purely on the duration of the disease, and they actually excluded patients with multifocal leaks and with more extensive, although they didn't specify that, more extensive RPE changes. So the more severe chronic cases, based on the phenotype, were actually excluded, which is a pity. And they had 12 months of follow-up, so more follow-up, I guess, is needed. So we also performed another large prospective randomized control trial in the Netherlands, in which my colleagues were, of course, also actively involved. And we compared half-dose PDT to oral eplerenone treatment. And completely surprisingly, when taking the Vichy trial results into account, we found a marked superiority of PDT with 78% of complete resolution over eplerenone, which interestingly had a complete resolution in 17%, which is almost the same as in the Vichy trial. And there was also a benefit in terms of retinal sensitivity. So to conclude about the main trials of the treatment and the fact that prospective trials are essential, the PLACE trial showed that half-dose PDT is superior over micropulse laser. The Vichy trial showed that eplerenone is not better than placebo. The SPECTRAL trial has shown that half-dose PDT is indeed superior over eplerenone, and possibly there might be a role for 577 nanometer micropulse laser, although we need more studies for that. So is it a miracle treatment, PDT? Well, certainly not. There can be patients with already quite a lot of atrophy who might not respond, or with cystic changes. And what if the first PDT treatment does not work? Well, we have recently published another paper by Jenny Chang-Wolf, one of the PhD students, that a second or third treatment can actually be quite effective still, although the likelihood of a response is lower in general, which was also the case in the PLACE trial, than the first treatment. But it's worthwhile redoing the FFA ICGA, apart from reconsidering your diagnosis, of course, to see if there's still active leakage. And in that case, I think you're especially likely to have a response. So in severe phenotypes like these horror cases, it can still work, actually quite good. We published about that too. There's a good likelihood that you get a resolution of fluid and even intraretinal fluid in 1/3 of the patients, also intraretinal fluid, but the visual acuity will not improve that much because of the atrophic changes. Factors that, of course, affect the outcome are baseline visual acuity that is poorer, or an RP atrophy involving the fovea. Here's such a case. I will never forget, there's an Iranian man who was already blind in his other eye from extensive atrophy. He had sarcoidosis using prednisone, a lot of leaks. And we treated him with PDT. The OCT at baseline already looks horrible. Look at his huge choroid. We did a PDT, and it quieted down quite nicely, but the vision didn't improve because of all the damage that was already there. Now, if you want to read more, an extensive review on the evidence-based treatment of central serous chorioretinopathy and the guideline that we published, you can read this paper, which was published with an international group of experts in the field, also including Dr. Van Dijk and Dr. Eijzer, and it's available for free. And we propose a management flowchart for acute CSC and chronic CSC. And to wrap up, this leaves us with the question, why does PDT work best at present? Well, I guess you get the gist. It's a more direct and rapid treatment of the primary problem, which is the choroid and the secondary RPE leakage. Is more effective in getting rid of the fluid rapidly compared to, for instance, laser treatments. And it also leads to less recurrences, as we have shown some years ago. And then an important question that comes up often is, but is it safe also on the long run? Because especially the older colleagues remember sometimes the cases of ischemia and AMD. But bear in mind that AMD is a completely different disease with a very sick RPE, with a very thin choroid in general. So, but we looked at that. You have to prove it, right? So we looked at all the patients who actually also had their fovea included in the place in the SPECTRA trial. And we found that at 2 years of follow-up in the patients who had a single treatment with half-dose PDT, there was a marked anatomical and functional improvement in all of these patients, and none of them developed any atrophy of the outer retina. So you can safely treat with half-dose PDT involving the fovea. So PDT in chronic CSC is effective and safe, but there are still some open ends and problems. Of course, there are still a highly variable practice pattern. That's why we give this course, by the way. We don't have good large randomized controlled trials on acute CSC yet. There has been no prospective trial comparing PDT with placebo, but that is going to come, the PAIN trial in the UK. And there is a very limited choice in terms of alternative treatments if PDT doesn't work. So we need more trials, we need replication, and of course the elephant in the room is that PDT is sometimes not available, and there's a shortage worldwide, which we'll probably discuss in the discussion later on. So the current evidence suggests that PDT is the most effective and it is safe. Observation can be employed in acute CSC, but consider early treatment in cases that might necessitate early treatment. PDT treats the choroid and hence is probably the most successful. More treatment options are needed, and that's what I wanted to tell you. Thank you very much.
Yeah, thank you, Camille. We're wondering if there are questions from the room. So when there are any questions, please come forward and pose that question.
We've got 20 minutes for questions and discussion, so feel free to
pose questions and not leave the room.
Yeah.
I was wondering, Camille, could you elaborate a bit more on the verteporfin shortage, and maybe also in that line a bit, if there's any role, for example, for no-dose PDT or other treatments that were designed in the, let's say, shortage period?
Yes, yeah, that's an interesting point. Still work, yeah. So many countries, including the Netherlands, have experienced quite a shortage or even absence of Visidyne. And I know that there are still countries in the world where there's no Visidyne available, but there are some countries where it's very well available, including the Netherlands, which is quite striking. Why is there such a variability? But anyway, so when there was such a shortage, there was one paper discussing not giving any Visidyne, but just putting the laser spot on there. That would be really nice, right? But I don't think there's very good proof. Thinking also back about the likelihood of spontaneous resolution, no good proof to follow that route. With regard to the current shortage and the also announced new shortage that is coming, we really need other initiatives to make Visidyne, verteporfin, available, because there's only one company, one factory in the US that apparently has a production problem. So if that stops, we don't have any Visidyne anymore. We cannot treat PDT with PDT anymore, also for hemangioma, etc. Fortunately, I know of a company based in the Netherlands that is exploring the development of Visidyne, the production of Visidyne, but it's an extremely difficult product to make. So this is going to take at least 1 or 2 additional years, and hopefully this company will succeed, but that would be really, really nice if there's a competitor in the field.
Yeah, thank you. I see a question from the audience.
Thank you for your talk. Can I just ask a question? Are there any variations in use of anabolic steroids versus catabolic steroids in causing CS?
Yes, so when you have a look at the literature, there's not a clear, let's say, difference in terms of dosage and mode of administration. There are even papers available that tell us that topical steroids, so when you use steroid drops, there's not an increase on CSC, and also there's not a clear difference between high-dose oral steroids versus intra-articular injections versus all different modes of administration and dosage. So, and also in the types of steroids, so anabolic steroids versus other types of steroids, there's not, at least there's not a clear difference found in literature.
One more question. I've had a couple of patients who are taking human growth hormone for bodybuilding, and they both had CSR. When they stopped it, it got better. Are there any reports on human growth hormones causing CSRs?
Yeah, so I think I've read a few reports that could also contribute to the CSC, yes indeed, and that when you then advise those patients, which will be very challenging because they are, let's say, addicted to the stuff, but that it would really help in the treatment. So I think the first and most important step in treating a CSC patient is really to find out if there are any risk factors, so steroid use, endogenous hypercortisolism, anabolics, and only then we come to the, let's say, the treatment tree like Professor Bohn just presented.
I think an important point to make here, by the way, also is, of course, you want to try to get rid of those medications, but in many instances it's not possible. And for instance, also thinking, I've seen several patients, and I'm sure my colleagues also seen them, of gender transition patients who take testosterone and get CSC. Still, a treatment like PDT can work. That's our experience, right? So we're not sure if there's a high risk of recurrence, but PDT can still work. So if you cannot stop it, do think about treatments.
May I comment too? It's I have a case that she has SLA. When she's on prednisone on 7.5 milligrams, there's no problem. When she is increased to 10 milligrams of prednisone, there's subretinal fluid in both eyes, but like everywhere. So I think it's dose dependent.
Indeed, yeah.
Hi, thank you for the great course. Romy from Manchester, UK. I just wanted to ask about pachychoroid neovasculopathy. Is there an evidence base for combination treatment? So for example, in those cases, as a first line, we would start anti-VEGF. But what we find is those cases are very resistant to anti-VEGF treatment.
Yes.
And in that situation, after trying anti-VEGF for a while, I do try to do PDT. But
Indeed.
What's your experience?
I think that's a very interesting point. So the question was, if you have pachychoroid neovasculopathy, so this mixture between CSC and a neovascularization or a combination. So what happens is that the large vessels compress the inner choroid, so there might be ischemia, and that can be a type 1 MNV. The question is it mainly the MNV causing the fluid, or is it mainly the CSC or a mixture? So FFA and ICGA can be quite helpful there. So if you see signs of more typical CSC, like focal leakage and more extensive choroidal abnormalities that are typical of CSC, then I would be having a very low threshold of also adding half-dose PDT. But you could easily also maybe combine it with a few injections. Some years ago, I gave a presentation for the Singapore Ophthalmological Society exactly about this topic, and there is no good prospective evidence, but there are some nice retrospective or smaller studies that suggest that, first of all, as you already mentioned, the neovascularizations are not as responsive to the anti-VEGF treatment as we know from other diseases like AMD, probably because the neovascularizations are relatively inactive or slowly leaking, and the CSC component may be larger. So, long story short, combination treatment is probably quite a good idea.
What kind of anti-VEGF would you use, Camille?
Well, in the Netherlands, we are a Western country, so I would start with bevacizumab, and if it doesn't work, you might switch to something else, but I don't think there's a clear preference.
It's Maciej Gawecki from Poland. Oh, I have two comments, or I would like to know your opinion about, I think, two groups of patients that we can think about. The first one is like the Iranian patient that you showed us. I think the group of patients with no potential for improvement that would benefit from no treatment, in fact. Because I have seen a few cases of half-dose PDT performed in chronic cases with a lot of alterations in neurosensory retina and at the RPE that in fact have subjective decrease of vision after dose PDT. So that's the first question. The other one concerns the acute cases. Well, there are just two, I think, randomized controlled trials that compare the contrast sensitivity of patients treated with micropulse versus no treatment. So would you choose, for example, micropulse in acute cases, or would you rather wait and observe?
Yeah, so thank you. So to start with the last question, it depends on the patient, of course. So if there's no professional need for a very fast recovery, I think I would choose for watch and wait for, let's say, 6 weeks to 3 months. And but if it's a recurrence or they need early resolution, I would personally go for PDT based on the studies that are there. You could also try 577 nanometer micropulse, and then if it doesn't work, use PDT later. But there's of course a high likelihood of spontaneous resolution. So it's easy to say, the treatment works, but there's a high likelihood of spontaneous resolution. With regard to the severe chronic cases, I completely, based on my experience, confirm what you see, that it is difficult to improve them because of the damage that is there. Your point of vision getting worse after the PDT is something, based on my experience in more than 1,000 patients, that is not something that I've seen thus far. And we've looked actually into that in a group of patients, and there were very few patients where we even had a hint of some decline. But I don't, of course, there's some cases that have been described, but I wouldn't be too worried about that. It's mainly that they probably don't improve that much.
Thank you very much.
Yeah, Camille, I completely agree. So we see after PDT or other kind of treatment in these very chronic cases that subretinal fluid and intraretinal fluid disappears. And I think it may actually not improve vision in these cases, but they may preserve their vision. So I think it's still worth treating these cases.
I agree. Thank you.
Hello, everyone. I'm Dr. Abbas from Iraq. So we all agree that persistent subretinal fluid is an indication for treatment, but what about PEDs, central PEDs? They might be severe enough to induce metamorphopsia. And for someone like me who does not have PDT, what should I do for such patients?
Yeah, that's a very interesting question. We can discuss that. So there's very little evidence, because many people, for instance, with PDT are hesitant to treat such a central PED because of being afraid of inducing atrophy, etc. But if it's a very central, large PED, it can have quite a lot of symptoms. So what I would do in that case is, first of all, of course, it's an open door, make sure that it's really CSC and not, for instance, confluent drusen or whatever. So do a FFA ICGA. If you see the typical leakage of CSC, okay, you know that the choroid is the primary problem. We've treated a fea patients with half-dose PDT because they said, I really want treatment because I have so many complaints. And they do quite well, but it's a small number. And there's only one paper, as far as I know, from the Michael Larsen group in Copenhagen in about 15 patients who had similar findings. But if you don't have PDT, yeah, try something else. But it's even less evidence-based, right?
So I know it's quite controversial, and I'm probably the only one in the room here, but I treat those patients with Pret Forte, so a steroid eye drop. And I don't know why, but I have also this very small number, but I think in 3 cases really good response on when they only have a PED. In PED in pachychoroid, in the pachychoroid spectrum, I've treated those with topical steroids, and they responded really well, but they all had a very high intraocular pressure as a response. So you really have to do close follow-up on these cases, but it may be worth a try.
And thinking out loud, I can also think like there have been reports in which choroidal remodeling has been seen even if there are anti-VEGF injections. So when you don't have options, there's no fluid. I didn't do that myself because we got the luxury of having PDT, but at least when you want to do something, you could also consider maybe to do anti-VEGF injection, but it's not proven and not seen in large reports.
I have only the micropulse 577. I don't think it will do much in the absence of subretinal fluid. I guess you agree. One last point. Have you noticed an association with thyrotoxicosis?
With what?
Thyrotoxicosis, CSCR with thyrotoxicosis?
It didn't come to my attention, actually, no. But it's, of course, very rare, and then the combination of CC is rare, so it's difficult. But I'm not aware of that. But so sometimes people say, well, PDT and verteporfin is expensive. Well, it is expensive, but it's often a one-time treatment. So all these people who say that and are treating, in the meantime, treating patients with anti-VEGF time and time and time and time again, I would say, well, maybe you should consider, if you see a lot of CC patients, to think about well, integrating it into your practice.
Katarzyna Roguska from Poland. We don't have access to Vizudin. It's very difficult to do PDT treatment in Poland, so we rely mostly on micropulse. And I have a question about micropulse specifically. Would you recommend increasing or decreasing powers in the settings you presented on your presentation? And how often would you recommend repeating micropulse, and when to do a control afterwards?
The short answer is I have no idea, because nobody knows what the best settings are. We chose to use a very high power because we wanted to avoid people saying, yeah, well, you used too little power. And, but the answer is that nobody exactly knows what the best titration is. So it's impossible to give you an answer to that, unfortunately. So we need trials for that.
Okay.
And why do you think, why can you not have Vizudine in Poland? What's the reason? Okay, you do have
but
it.
maybe I will discuss it.
Yeah, I mean, we have an evidence-based guideline now, so it would be more easy to have that in your hand to convince the regulatory bodies to say, okay, this is the evidence, so you have to reimburse it. Okay, good to hear. So it's reimbursed. Okay. Yeah. Good to know. Yeah.
Last questions, Irina. My question's about BSS solutions. I saw that was experiments like BSS helped with central serous chorioretinopathy. That was like experiment, like BSS solutions.
BSS? You mean what BSS. We use in surgery?
Yes, with surgery. Like intravitreal and help with more faster reabsorption with central serous.
CSC.
Yeah, CSC.
So you mean you inject the BSS solution that you use, for instance, for cataract surgery, and you inject that in the vitreous?
Yes.
Well, there's no evidence for that. Okay. No, there are no good studies, so it's difficult that you cannot answer that. No. Okay. I didn't even come across any study that did that, so I wouldn't do that, I think.
Okay, thank you.
But I think it's with every treatment, right? So you really need randomized controlled trials in order to find out if it works, because the spontaneous transfer of resolution is so big. So yeah, they can say everything about every treatment, but when you don't test it in an RCT, it's not known if it works.
Elon, are there any online questions?
Yes, so I was just about to say there's a comment online which we haven't discussed, but it's very important too. And the question is if we can try focal argon laser. And I think we can, yes. Even in chronic cases, if you find a leakage spot, you can, and you don't have access to PDT, for instance, you can use the argon laser. Sure. And it may have very good effects as well. And well, you're treating the leak, which is the tip of the iceberg. So the choroid that's still smoldering below, you're not treating. But if you treat the leak, it can be quite effective. So it can, yeah. So if you don't have access to PDT, indeed, it's cheaper. And so Camille. You've discussed that you can repeat the PDT. Is there like a limit? Like how many times would you treat a patient or an eye with PDT? Well, I think the likelihood of a response becomes smaller stepwise. So in our clinic, we haven't treated more than 3 times in the same eye. And of course, then the question is, does that induce problems or atrophy? The answer to that is no. We've looked at that in quite a large group. But I would say 3 times, and then you have to stop, because if it doesn't work, it doesn't work. Yeah.
And I would think every time you are considering to repeat the PDT, please redo your FA-ICGA in order to find out if there's anything to be treated, or if there's another diagnosis that could underlie the accumulation of the fluid. Maybe a question also for you. So in some patients, when half-dose PDT didn't work and it was a typical CSC, I did a full-dose PDT. But in the few cases where I did that, often they also didn't respond. But what's your experience with that? Do you have experience with that? Yeah, so we don't use that, let's say, full-dose PDT or 75% verteporfin PDT at all. So in central serous, the only thing you need to do is usually half-dose PDT. You would even be more, let's say, have a bigger tendency to do half-dose because of the verteporfin shortage. So that's better to do than half-time or half-fluency. So I don't use that.
I think it's very important that if you don't have a response of your PDT treatment, that you redo your imaging,
Sure.
because these patients have very thick choroid.
That's working.
Hi, can
Working.
you hear me?
Yeah, yes.
Yeah. So I'm Sam Candario from Southampton. Hi there. I've got a question about a few patients we had who, when we couldn't get verteporfin, this patient with CSCR were losing vision, and we overall felt that there's no real evidence to offer them micropulse laser. So unfortunately, there's nothing we can do for these patients. What's your feeling about that? Do you think we should offer these patients micropulse laser, even though the evidence is not that strong?
You mean as a primary treatment?
Yeah, so when there's no verteporfin available.
Oh, when there's no verteporfin. Well, I think this 577 nanometer trial, despite of course the caveats that I've discussed, does indicate that there might be a possibility that is working, right? But I think we need stronger evidence. But if the patient has a lot of complaints, there's no verteporfin. The only two treatments that I would consider then are focal laser, focal argon laser if there's an eccentric leak, or maybe 577 nanopulse treatment based on that study. But yeah, there are some question marks there, I think. So I agree that with your points.
And there's still one. There's lots of echo.
Hi, Fadwa Ladal from Saudi Arabia. How long do you wait before your second PDT session?
Before the second PDT?
Yeah, 3 months?
I personally wait a maximum of, let's say, 3-4 months. If the fluid is not gone, it will not go away. So
Right.
if I see in the back at 3-4 months, I treat them.
Well, I won't comment.
There's still. No.
There's one question in the Q&A, but I cannot see it. If there's a role for anti-VEGF when there's no neovascularization. Well, there are no good studies on that. That's a short answer. So, as Elon said, there are some indications that some anti-VEGFs are relatively successful in reducing the choroidal thickness. So, there might be a role, but there are no good studies. So, well, this is a course on evidence-based treatment, so I couldn't recommend it. But yeah, if you don't have PDT available, and you should look at your armamentarium, discuss it with the patient. But the bottom line is that there's no good evidence. So, if there are no more questions, I would like to thank you very much for coming. Have a great lunch, and all the best during the rest of the conference. Thank you. Also on behalf of Elon and Susanne.